everyone, and welcome to a new episode of MemoMap. Today we will start exploring the most important system, which is the respiratory systems. And we will begin with a simple, clear introduction. And in this video, we are going to talk about the organization of the respiratory system, the main function, the mechanism of breathing, and the basic respiratory mechanic. Let's start with the organization of respiratory system. To understand the respiration, we need to answer two main questions: what are the different zones, and what is the function for each zone? First, we have two types of zone: the conductive zone and the respiratory zone. The conductive zone is starting from the nose, larynx, trachea, bronchi, and bronchiole, while the respiratory zone is the respiratory bronchiole, the alveoli duct, and the alveoli. The function of the conductive zone is to transport air, warming, and humidification of the air, as well as defense, while the respiratory zone main function is the gas exchange. Remember that the alveoli has three types of the cell: the type 1 for gas exchange, 2 for surfactant, and macrophage. So conductive zone conduct the air, warming and humidifying the air, as well as defense, for it's from the nose to bronchiole. Respiratory zone only for gas exchanges, and it's respiratory bronchiole and alveoli. Now that we understand the organization of respiratory, let's move to the main function, which is the respiration. Although the lung has many rules, but today we are going to focus on the respiration. And here we need to focus in one important thing, that we have two types of respiration: the external and the internal respiration. The external respiration is continuous processes, including four main steps. First, the pulmonary ventilation, in which the air moves in and out of the lung, and gas exchange, in which the gas, oxygen, carbon dioxide, moving between the alveoli and the blood. Transport of the gas in the blood, in which the oxygen is transported as a dissolved form or carried by the hemoglobin, and then tissue exchange, which occur between the blood and the cells. Oxygen move from blood to the tissue, and the carbon from tissue to the blood. And the internal respiration, and this occurs inside the cell in the mitochondria. And here the mitochondria use the oxygen to produce an ATP and carbon dioxide. So the complete respiration started by pulmonary ventilation, alveoli exchange, transporting via hemoglobin mainly but not only, tissue exchange again, and ATP production, which is the internal. Now let's move to the first step of respiration, which is the pulmonary ventilation, and here we will understand how breathing occurs. First, what are the phases of ventilation? We have three phases: inspiration, air go in; expiration, air go out; and the pausa, brief stop between the breaths. How the air move: air flow low. To understand the ventilation, we go back to the key principle of airflow, which equal pressure gradient over the resistance. So this means the air move due to the pressure differences. And here we are talking about two main pressures: the atmospheric and the alveoli. Starting with atmospheric pressure, at sea level it's around 760 millimeter mercury, and it's constant. And so let's move to the alveoli pressures, which is expressed in a relation to the atmospheric. So if it's equal to the atmosphere, it's 0. If it's higher than the atmosphere, it's positive. If it's lower than the atmosphere, is negative. And it's always 0 except during the inspiration, which is -1, and during expiration is +1. So how does the alveoli pressure change? This depends on the intrapleural pressure. What is the pleura? The pleura is the membrane covering the lung, and it has two layers: the visceral and parietal layer, and the pressures inside the space between the two layers is always negative. However, during the in the end of the expiration, it is -3. At the end of inspiration become more negative, it's around -6. And however, and also with the forced inspiration it become more and more negative. It reach up to -30, and with forced expiration it become +50. uh, and from here, we need to estimate the transpulmonary pressures. The transpulmonary pressure equals the alveoli pressure minus the pleural. Consider the alveoli pressure is 0. So, and the pleural pressures under normal inspire is -3, and then become -6. So the transpulmonary pressures is around either 3 or 6 with the normal inspire and expire. And remember that when the transpulmonary increase, the alveoli expand. When the transpulmonary decrease, the alveoli recoil. So let's move to the question why the pleural pressures is negative. The two main reasons for this is the opposing force and the surface tension. The opposing forces mean that the lung tend to collapse due to the elastic recoil and the elastic tissue in parenchyma, while the chest tend to expand due to the elastic in the muscles and the tendons. What about the surface tension? The alveoli lined by the fluid and the water molecule always tend to attract each other, and this creates a surface tensions, and this tend make the alveoli tend to collapse. So, how to decrease the surface tension? By surfactant, which is a substance secreted by type 2 alveoli cells and is formed of phospholipid protein calcium, and its main function is to cover the water molecule so they won't be able to attract to each other. This decreases surface tensions, and since the surface tensions is decreased, the alveoli tend to expand easily and prevent the alveoli from collapsing. Also, it prevents the fluid accumulation in the alveoli and protect from the edema. Now that we understand the pulmonary ventilation, depending mainly on the change in the intrapleural pressure, let's simply ask the following question: how does the intrapleural pressures become more or less negative? And here we need to talk about the respiratory muscles, the role of the respiratory muscles during the different type and phases of respiration, starting with the quite normal inspiration. During the normal inspiration, two main muscles contract, the diaphragm and the external intercostal muscles. So what happens? The chest expand, the two layers of the pleura, the visceral and parietal layer, move apart, so the interpleural pressures become more negative. And this expanding the lung allows the alveolar pressure to drop up below the atmospheric, so the airflow into the lung. With quite normal expiration, no muscles contraction is needed. Rather, the muscles relaxed and the lung recoil due to the elastic properties in its tissues. So the alveoli collapse but with high volume from the inspiration, and this increasing the alveoli pressure above the atmosphere, so the airflow passively outside the lung. So remember, the expiration is passive and the normal inspiration is active. Forced inspiration, we do it during exercise or with an asthma. Here we need to do the deeper inspiration, so we need more muscles in addition to the diaphragm and the external intercostal, which are the sternocleidomastoidal and the scalene muscles. And both muscles or the four muscles, when they contract, they expand the chest more and more, increasing the negativity of the intrapressure in the pleura. Intrapleural pressures, it become -30. So remember the two muscles for the forced inspiration started by S, sternocleidomastoidal and the scalene muscles. What about the forced expirations, which we may use it during exercise or the asthma? Here two muscles are involved, and this is the first time we use the muscles during the expiration. which is the internal intercostal and the abdominal muscles. So when the abdominal muscle contract, increasing the intra-abdominal pressure, pushing the diaphragm upward, and this make the intrapleural pressures positives around positive 30. So the normal inspiration active, diaphragm external intercostal. The expiration, normal expiration, is passive, just by elastic recoil and relaxation of previous two muscles. The forced inspirations are four muscles: the diaphragm, external intercostal, and two S muscles, sternocleidomastoid and scalene muscle. The forced expiration is the internal intercostal muscles and the abdominal muscles. Now we reach to the final part of today's video, which is the respiratory mechanics, where we translate the following numbers and the measurable functions. Here we are going to discuss the lung volume and capacity, the airway resistance, the dead space, and the pulmonary and alveoli ventilation. So start with the lung volume. We have four basic lung volume and four basic capacitance. First, the tidal volume, which is the air move in and out during normal breathing. The second is the inspiratory reserve volume, which extra air inspired above the normal inspire. Expiratory reserve volume, extra air expired after the normal expire. And the residual volume, the air remaining in the lung after the maximum expiration, so cannot be expelled. The lung capacitance are the calculated from the previous volume, and they are four. The total lung capacitance, which is the volume in the lung after the maximum inspiration. So if we want to estimate the total lung capacity, so what we have to do is to sum the four volumes. The vitals capacity, which is the maximum air expelled after the maximum inspire, so it equal all the volume except the residual volume, because it cannot be expelled. So we have three volume, removing the residual volume. The functional residual capacity is the volume remain after the normal expire. So if we expire normally, inside our lung we have two main volume: the expiratory reserve and the residual volume, and this is important to stabilize the gas exchange and prevent the large fluctuation in oxygen and carbon dioxide. Last but not least, the inspiratory capacity, which is the maximum inspiration after the normal expire. So this equals the tidal volume plus the inspiratory reserving volume. So clinically, we have two others important parameters for pulmonary function, which is the forced vital capacity, which is maximum inspire followed by the forced expirations, and the forced expiratory volume in the first second, which is the volume exhaled rapidly in the first second. And we also need to estimate the ratio between them, and usually the FEV1 is about 80% of the forced vital capacity. Both parameters are important to differentiate between the obstructive lung diseases, disease in the airway as in the asthma, or restrictive lung disease, which is a disease mainly in the lung tissue like fibrosis. In obstructive lung disease, all parameter or both parameters are markedly decreased, but in restrictive, the FEV1 and forced vital capacity are decreased proportionally, so the ratio either remain normal or slightly increased. Now let's move to the second point, the airway resistance. Remember that the flow equal pressure over resistance, and the resistance is inverse proportional to the radius. So here, remember, in the airway, the highest resistance is present in the medium, and not the smallest airway. Surprise, yes. Despite the small airway has this small radius, but here we depend on the cross-sectional area. So the medium bronchi, which has a total cross-section area less than that of the small bronchiole, it has a higher resistance. So the higher resistance is present mainly in the medium bronchi, and it's not in the small bronchi. This due to the smaller total cross-sectional area. What are the factors affecting the resistance? Mainly physical, hormonal, and nervous. Physical, nervous, and chemical. The physical, during inspiration, the airway expand by the negative intraplural, and this decreases the resistance. And second thing is the expansion of the alveoli cause a radial traction, and this decreasing the resistance. For the smooth muscles of the bronchi, we have two nerves, parasympathetic and sympathetic. The parasympathetic causing a contraction of smooth muscle and bronchoconstriction, increasing the resistance, while the sympathetic cause a relaxation of smooth muscle, causing bronchodilation, decrease the resistance. The chemicals that increase the resistance by direct effect on the smooth muscles are the histamine and allergen like the pollen. The third point here is the dead space. What is the dead space? Is ventilated air without gas exchange. Simply to say, the air in our respiratory system which does not undergo a gas exchange. And this is simply represents the air in the conductive airway, or we can say the anatomical dead space equal the air inside the conductive airway, because this air will not go in gas exchanges. However, under a pathological condition, we could have a physiological dead space, in which, in addition to conductive airway, we have a non-functional alveoli. So here, to estimate the physiological dead space, we add the non-functional alveoli to the anatomical dead spaces. So, under normal, the dead space equals the anatomical conductive area. Under the disease, we have a physiological, which is more than anatomical, because we include also the non-functional alveoli. Remember that the air in the dead space cause a dilution of the alveoli air, and this make a difference between the inspire, expire, and alveoli air, with the alveoli have the highest carbon dioxide and lowest oxygen tension when compared to inspire and expires airs. And now also in this point we need to emphasize about the effect of the pattern of breathing. When we breathe deep, we ensure that some of the volume of the air go to the alveoli, so this increasing the alveoli ventilation. But when we breathe rapid and shallow, a few air go to the ventilation, since most of the air which we take it stay in the anatomical conductive zone, so the alveoli ventilation decrease. So when we take a rapid shallow breath, this will decrease the oxygen tension and increase the carbon dioxide tension. Now let's move to the last point, which is the pulmonary ventilation and alveoli ventilation. To estimate the pulmonary ventilation, it equals tidal volume times the respiratory rate, and to estimate the alveoli ventilation, it equals tidal volume minus dead space multiply the respiratory rate. And remember that the alveoli ventilation is less than the pulmonary ventilation. Now we reach to the end of today's MemoMap. Let's summarize everything in clear, structured way. First, the organization of the respiratory system. We have two zones: conductive zone, nose to bronchiole; respiratory zone, respiratory bronchiole to alveoli; conductive transport warming; defense, respiratory gases exchange. And the steps for respirations are 5. 4 for external, including pulmonary ventilation, exchange of gas, transport of gas, and tissue exchanges of gases. And the internal respiration, which is the cellular respiration in the mitochondria for production of the ATP. Focusing on pulmonary ventilation, we have 3 phases: inspiration, expiration, and pause. And the key here is the flow equal pressure gradients over resistance. For the pressure, we have the atmospheric and the alveoli. The atmospheric is constant while the alveoli is zero since it equals the atmospheric, but it could be less than the atmospheric during the inspiration or more than atmospheric positive one during the expiration. Changing of the alveolar pressure depend or due to the change in the intrapleural pressure, which is always negative, and it become more negative during inspiration and only become more positive with the forced expiration. Why is it negative? Because of two reasons. The opposing forces, the lung tend to recoil while the chest tend to expand by its elastic tissue in the muscles and the tendon. And the second cause is the surface tension, which is reduced usually by the surfactant, which is produced by type 2 epithelial cells, and it is formed of the phospholipids, proteins, and the calcium. What is the role of respiratory muscles in the pulmonary ventilation? The respiratory muscles is responsible for the changing of the pleura by moving the two layers of the pleura away or near to each other. So with inspiration, it is an active processes, diaphragm and external intercostal contract, and with expiration, it is passive processes, no muscle contract, and there is elastic recoil. With the forced inspiration, in addition to the diaphragm and external intercostal, we have two S muscles, which are sternocleidomastoidal and scalene. And for forced expiration, for the first time, we use muscle for expiration, which are the internal intercostal and the abdominal muscles. In respiratory mechanic, we discussed mainly the lung volume, which are tidal, inspiratory reserve, expiratory reserve, residual volume, lung capacity, total lung capacity, all volume, vital capacity is all except the residual volume, functional residual is expiratory reserve plus the residual volume, the inspiratory capacity, tidal volume plus the inspiratory reserve volume, and don't forget the FEV1 and the forced vital capacity, since both of them differentiate between the obstructive and restrictive lung disease. The airway is the resistance. Airway resistance inversely related to the airway radius. However, the highest resistance presents in the medium bronchi because of the smallest cross-sectional area. This resistance is affected by the physical factor, expansions of the lung, so more lung volume mean attraction of the respiratory bronchiole, and this decrease the resistance. In addition to the physical factor, we have nerve and chemical factor. The dead space, we have anatomical, which equal conductive zone, and physiological, which include the air in the conductive plus the air in non-functional alveoli. Remember that physiological, the dead space is more than the anatomical dead space. And finally, we talked about the pulmonary ventilation, which equal tidal volume multiply respiratory rate, while the alveoli ventilation is tidal volume minus dead space multiply the respiratory rate. So that's all for today. See you in next MemoMap episode.